Our next, our next session is ECMO Simplified. I would like to request Dr. Riyan Shetty as a speaker. Dr. Shetty is the consultant pediatric intensive care at Narayana Health, Bangalore, and he's the head of ECMO at Narayana Hospitals, Bangalore. I would also like to request our chairperson, Professor Shubroto De, to please come up on the stage. He is professor and head of the department of cardiothoracic unit at Medical College and Hospital, Kolkata.
Good morning. Now we are starting a new session, ECMO, and discussion will start by Dr. Riyan Shetty. I know Riyan Shetty for many years. He is the chief of ECMO unit NH Bangalore, and he has wide experience about ECMO. I have seen working in ITU of NH Bangalore, managing 3, 4, 5 cases in ECMO after post-op and pre-op congenital cardiac complicated cases. Dr. Shetty, please start.
I'm having a little bit of problems with technology. Is there a... I did give my talk to be checked, but it looks like... Oh no, I don't have internet. Can you go to the next?
You can WhatsApp me.
Yeah, can you go to the next talk?
Okay, sure.
Please.
We'll see. Yeah, next talk.
Can you ask?
Next is our case presentations. So if they are ready, can we go?
Can you connect this one there?
That is a Dr.
Connector? Connector you have?
She's there.
Okay, what do I do now? Because it's there here.
Dr. Professor
मेरा उत्तम है
उत्तम किधर?
We have the presenters.
Okay, I can send it to your WhatsApp. Yeah, I can send it to your WhatsApp. Yeah.
9789.
I'm so sorry. Okay, thank you for waiting.
9789 877 851. Okay.
তাহলে অ্যানাউন্স করতে হবে ঠিক করে এটা যদি ক্যান্সেল হয় তাহলে অ্যানাউন্স
First guest presentation because he's taking some time. USB is not. Okay, so okay. Get a pen drive here.
That way also we can, if you send it to him.
Yeah, also I can put it. Yeah, just put it here. It's there. It's not working. Pen drive there. It's working here. I don't know why. Maybe it's a Mac and I don't know. I send it by WhatsApp to you. Send it to her.
You send it to me. I can collide it.
I think we were keeping up time very well and we jinxed it. Sorry about it. Should I start? You got it? Okay. Okay. Good morning, everybody. Thank you very much. I'm sorry for that delay. On the offset, I would like to thank the organizers for giving me the opportunity, especially Shubhadeep, who was pushing me very hard to come here, and I'm so glad I did. So I'm going to talk about ECMO simplified. What means is I'm trying to finish off a large topic in 20-25 minutes. It's not going to be easy, but I'll try to touch upon as much as possible. Yesterday we had a beautiful workshop where we discussed most of these points. For some of them it will be a repetition. So I come from Bangalore. We are from Narayan Hrudayalaya. We are one of the largest cardiac ECMO centers in the world. We do about 130 ECMOs, out of which around 60 are pediatrics. And ECMO is a part and parcel of our day-to-day job, just like a ventilator or any other machine. And over a period of time, we've got to learn a lot from this technology, and so I would like to share a few things of those experiences. It's come? Yes, sir. Okay, just take your time, no problem. Okay. Just don't drop anything.
এখানে কোনটা কপি করে দিস?
আর হোয়াটসঅ্যাপে নেই তো,
না না
আমরা তো কপি করি।
এইটা না কপি করে নিয়ে হোয়াটসঅ্যাপে ডাইরেক্ট করে। এটা তো
They don't have the connection. It's come. Sorry, thanks. Okay. I'll try and finish in 20 minutes. So can you show me? Okay. Thank you. So, I don't know how many of you have seen this movie. So my presentation is going to be just like that. Very, 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 very quick slides, flashing slides. So just beware. So I come from this part of the world. I was born and brought up in Mangalore. Whenever you go to Mangalore, you should go and see one of these. It's a ritual. We do that every year in my grandfather's house. It's a guy who comes and dances, and it's about spirit, and we believe a lot in that. We carry the spirit wherever we go. So whoever troubles is in maybe Kolkata or in US, we pray to him, and then he sorts it out for us, and we really truly believe in it. So my presentation also is going to be that. If you've seen the movie, it's really fast. You don't know what hit you at. That's how it's going to be. So all of you know what's ECMO. It's it's extracorporeal because outside the body membrane, because you use a heart-lung machine. You use an oxygenator, which oxygenates and takes out carbon dioxide, and it continuously pumps around the body. So quickly to go to the circuit, the cannulas, the venous side, those come and go into the pump. The pump is either roller or centrifugal pump. It goes then to the oxygenator. That's where the carbon dioxide and the oxygen, the elimination and oxygenation is done. So, and then it goes to the red part of the circuit, which is then going to the body, and depending on where it comes out and goes into the body, we define whether it's veno-venous or veno-arterial. I'll come to that later. This is 1971. This is the first, adult survivor. You can see how many things were attached in the intensive care, and that thing on the right is the water bath of the ECMO. Then there were some pediatric, survivors, and on a whole, this is Bartlett, Dr. Bartlett, father of ECMO. So from 1980s, 90s, they went on doing neonatal and pediatric ECMO, especially neonatal. And it's only, they established the ELSO registry and ELSO organization in 1989. We have a register where we can see that, you can see in the second part of it, there are 12,000 documented, this is a recent report, 12,000 documented runs which have been submitted to the ELSO registry. And you can see, if you see all the age groups except neonatal, the outcomes are really good other than neonatal, but the outcomes also are good in pediatrics, and outcomes are not that great in adults. So why I'm trying to put this on is because going forward, they try to see whether actually if ECMO saves lives. There's a question in the neonatal group, there's a question in pediatric group, there's a question in adult group. The question was only answered properly in the neonatal group. They did 3 consecutive studies, one on neonatal ECMO at the beginning, and then after a year of follow-up, and they did another one at 7 years of follow-up. They recommended that definitely neonatal ECMO is useful in the neonatal respiratory group. Coming to the pediatric group and the adults, there have been lots of studies since then, especially in the adults in 2009, and then recently they had the ULO study where they couldn't really say whether it's useful or not, whether it's indicated or not. So the debate is still going on. The reason I'm bringing this up here is there are many things in the pediatric intensive care that we learn from the adults, we extrapolate from the adults, we take studies from the adults and then put it on our age group. But this ECMO is one of the few ones, ECMO and probably nitric oxide is one of the few things that there is definitely good indications and there's research telling you it's useful in our age group, and they are actually trying to extrapolate these data and trying to see whether it's good in adults. That's one of the reasons I put this up. So the indications can be respiratory and cardiac. I'm not going to go through this because you will find it easily there's an ELSO website where they have indications for all these and how to run an ECMO program, how to train, how to transport. There are recent guidelines also on even in ECMO CPR. So you should, if you're interested in ECMO, should go up and look at that. The usual contraindications are lethal chromosomal abnormalities or uncontrolled hemorrhage. Those are the main ones. So. In pediatrics, not in adults, but in pediatrics and neonates, we use the oxygen index, the PO to FiO2 ratio or the oxygen index. That's something that you should understand. Anything about 20 is abnormal if it's going on for about 24 hours, or anything above 40, more than 4 hours is somewhere you start thinking that, okay, I think I need to call the ECMO team or refer to a nearby hospital. So why ECMO? It's just that we just cannot deliver oxygen and can't clear out the CO2. And that's causing a wide range of problems. So you can see so many things attached to this patient, and I think if we initiate such patient on ECMO, you can take out the nitric, you can bring down the ventilation, you can cut off half of the inotropes, you can rest the heart. If it's a lung, you can rest the lung. So that's where the indication of ECMO comes. But I showed you the indications, but it's difficult to see the indications and then decide on the timing of ECMO. So for that, I want to take you back to your medical college days. Oxygen delivery the equation is really important. It's dependent on cardiac output and hemoglobin and the oxygen content. So it's important to better the oxygen content. You guys all know this, 80%, 100% oxygen comes, there's a tissue demand, and then 20% goes off. So any patient going on ECMO or is on ECMO, these are some of the things we really look at very closely because we want to make sure there is good oxygen delivery and there's less oxygen consumption at the periphery. So this is one of Dr. Bartlett's nice contribution where if you see there's normal hypermetabolic, they're all normal. As soon as your patient starts going from 5:1 DO to VO2 ratio towards 3:1, that's when you start thinking these patients need ECMO. So it's okay to learn all the indications, but it's predominantly trying to see whether you can in the lecture previously also they spoke about how you should prevent organ damage, and when you start going that side, that's when your organ damage happens. So there's a constant debate, VA, VV. I just want you to take home this slide where you just, first questions you ask, respiratory failure, cardiac failure. Cardiac failure, you need veno-arterial ECMO. Like respiratory failure, you can manage with venous ECMO. But some respiratory failure who the cardiovascular instability is not because of hypoxia and maybe due to sepsis or some other SIRS response, then sometimes you might need veno-arterial ECMO. Still, you could go veno-venous and then convert to veno-arterial if your team is good. So just for the beginners, sorry, the dot is not synchronizing. So the blue blood comes in and the red blood goes back in veno-venous and veno-arterial ECMO. So the difference between veno-venous and veno-arterial is veno-arterial, you can give high oxygen delivery, you can rest the heart, you can have less pulmonary blood flow. But in veno-venous, really, it's just you're shunting out blood into a oxygenator, oxygenating a little bit. You really don't get much oxygenation. You still have to be somewhere around 80-85% saturation, which is fine, which is normal. So there's a little bit of difference. So veno-arterial ECMO, you're really taking control, but then the complications of veno-arterial are probably more than veno-venous. So what are the components you have? You have cannulas. We have, that's called the cone. And then you have the oxygenator. So when you attach all this and then put blood inside it, when you do pediatric ECMO, in small pediatric ECMOs, so you get a circuit like this where you have the console, you have the blender on top, you got a heater cooling unit in the middle, you can see the oxygenator, you can see the pump, and you can see a few wires here and there, pigtails and everything. So what's cannulas? When you come to cannulas, the most important thing you need to understand is the Pausley's law, and you have to understand the pressure and the resistance, the length, the radius. So that's very important, but it's difficult to remember all the cannulas. So we have algorithms for venous cannula, arterial cannula, how much flows you want, and what the French is, how much maximum flows will go through it. Similarly, even in the oxygenator, which is, it's like you want to buy a Bellino or you want to buy, a Mercedes, and you can even go for a Rolls Royce, okay? So there are pediatric oxygenators and then there are adult oxygenators. So if there are some companies which are very efficient, they stay for 30 days, 40 days, but there are also companies which will not last 1 week. But there are companies which have high pressure inside them, the transmembrane pressure is higher, but the companies with low transmembrane pressure also. So when you select your oxygenator also, it is like going to a shopping mall and picking it up. And this is the blender, I think all of you have seen that. So then we also pressure monitors on various things. When it's close to the patient, it generally tells you the CVP. When it's very close to the arterial side of the patient, it gives you the afterload. And then in between, there are two P2 and P3. The difference of that will also give you a transmembrane pressure across that oxygenator. Because one of the most important things you are trying to see when the patient's on ECMO is making sure the oxygenator is doing well, it's breathing fine, it is exchanging gas well. So this pressure is very important, and it's also called the delta pressure. Heater unit you have seen, and then there's always a controversy. Most of the countrywide, we use centrifugal pumps and don't use roller pumps. And also these tubes are also coated with heparin and albumin so that it becomes easier. The new roads in India that the government is developing, some of them are more smoother than the older ones. So that's exactly the concept. You're trying to reduce contact activation, you're trying to reduce reaction so that you have less anticoagulation on board, so that you have less bleeding and the complications of ECMO. So then I'll take a little bit of time here. So basically the flows, the left-hand side is the RPM, the right-hand side is the liters per minute. There's also a zeroing line, just like the CVP, to zero the flows. And there's a red line telling you don't go below 1,500 RPM, always be above that, otherwise the flow will reverse. On the other side, for cardiac arrest, I've mentioned that less than 10 kilos, you need higher flows, about 150 ml per kilo. That is about a cardiac index of 2.8. But in adults and smaller children, bigger children, you can go up to an index of 2.1. There are calculations for that. So you need full flows only when you want to take control. You want the heart to rest. You want maximum oxygenation. But when you're on veno-venous ECMO, you go for 2/3 or 3/4 flows, and then you work your way up, because increasing the flows increases oxygenation. So this is our own diagram just to give you quickly. There is on top, there is transcervical V ECMO on small children. We don't have veno-venous ECMO cannulas in India. for small children through the neck. Then you come to the next possibly is the left. Bigger children will go on a femorojugular veno-venous ECMO. Then you have on the top peripheral V ECMO for children who are more than 30 kilos. And then you do central V ECMO on emergencies and in post-cardiotomy. So, and this is the circuit. This is a very nice diagram to show you where the transcervical veno-arterial ECMO cannulas sit. One is in the distal innominate and one other one is somewhere sitting in the IVC. And Dr. Iyer's paper in 1990 telling the technique. Dr. Iyer is from Fortis Escorts, so when he was in Melbourne. So that's our contribution to transcervical echo, Indian contribution. And then when you look at this, you can see a small dot over here in the end. That's the IVC tip. And then the aortic cannula is somewhere in the distal innominate there. And then you always confirm all these by doing echo. You can see the arterial cannula in the distal innominate. Coming to femoral venous ECMO, I think you guys know about it. So this is a nice X-ray of a patient with ARDS, but you can see the cannulas are too close by, so there is a chance of recirculation. That's a concept seen in veno-venous ECMO, one of the complications. And then I would stop here and just take some time just to a couple of minutes, because this is my most important slide I want to explain. So you have a point? Okay. So you have the venous side. The native blood is usually of a PO2 of 40. If a patient is high, he's got septic shock, it will be even lower. It comes to the oxygenated, gets oxygenated and gets infused blood, which is very high, rich in oxygen. It's just like a normal lung. And then when it goes to the body, it gets mixed in the right atrium. This is the concept of veno-venous ECMO. It gets mixed there. You take 3 liters out, say for a big pediatric patient, you take 3 liters out, there's 1 liter which doesn't come out. That's the total cardiac output. It mixes, and you can imagine the saturation goes down to almost 88% in the PA. So that's why there is hypoxemia in veno-venous ECMO. So don't try to get higher oxygen. You won't be able to. Okay, so as you understand, there are 2 big things that affect oxygenation and veno-venous ECMO. One is the native blood PO2. If it goes down, you get desaturation. Number 2, if your cardiac output increases from 4 liters to 6 liters because of tachycardia, inotropes, or anything, or fever, then the ratio of the ratio of deoxygenated blood increases. So there is more desaturation. So try to understand in these lines. If you understand this much, you will be definitely okay to manage hypoxemia in veno-venous ECMO in your pediatric population, which is a little bigger. So in veno-venous ECMO, actually hemoglobin, you have a higher hemoglobin. You have risk of transfusion is higher. Risk of transfusion is higher, but you can run with lower flows. Lower flows means you need a little bit of anticoagulation because it can clot off. So you need to be somewhere in between. So mostly we intensivists are somewhere in between 12 and 13, 10 and 12 hemoglobin. Some hardcore intensivists want it 8. So there is always goods and bads. But definitely if a child is on veno-venous ECMO and is not doing well, the DO2, VO2 is low, please keep a higher hemoglobin, please keep a higher flow. Veno-arterial ECMO from the periphery, veno-arterial ECMO from the center. When we go on ECMO, you can see the systemic arterial pressure goes down. We take over the flows, and then when you're coming off, we're slowly weeding that off by using, first you rest in between, start inotropes, then you come off. So in veno-venous ECMO, respiratory failure ECMO, we always rest the lungs, so don't bang the lungs when you're in respiratory failure ECMO. All of you know that you need anticoagulation, so the gold standard is heparin. During heparin, if there is a heparin-induced thrombocytopenia, which is very, very rare in the pediatric age group, I have not seen one, then we sometimes go to bivalirudin. The most common way to monitor bedside is in India is probably ACT, and we then corroborate with the APTT ratio. We ourselves in Bangalore, we don't have access to anti-10A, but we try to keep the hemoglobin all right depending on the DO2, VO2, what we are requiring, and the platelet count goes up and down depending on whether it's bleeding or not, and also the number of times we investigate platelets. Sometimes it's only 24 hours, but if the patient's bleeding, we go up to sometimes 8 hourly also. So there's a huge variability in anticoagulation management in patients all around the world. So don't even get into that discussion. It's like a colloid, crystalloid discussion in pediatric intensive care hemodynamic, in the workshop. So what is best for you? Get ACT, APTT. How are you going to do this? Where are you going to document it? And where are you going to see the trends? And who's going to go up and down with the heparin is what you need to decide in your own center. So sedation and extubation, we keep them quite awake. Not the patients who are chest open, but then there are patients who are who are on cardiomyopathy or myocarditis. We even tunnel central lines, and if they're periphery, they also extubate VA ECMO patients. VV ECMO extubation is still controversial, but patients on cardiac ECMO can be extubated if they're waiting for a heart, or they're on full supports, and they don't need to be ventilated. If the lungs are all right and they can breathe, they can be extubated. They've been extubated for 10 days, sometimes even a couple of months waiting for a heart. So weaning VA and VV is very easy. You just come down on the sweep gas, but in VA we have to start inotropes, optimize everything, come down on the flows, FiO2 and sweep gas. So that's the difference. In VV you just come down on the sweep gas and come to off. Okay, there are lots of complications. A lot of people here, there might be 20% people who are believers of ECMO, then there might be about 80% are not believers of ECMO. So there are complications. That is the whole point. Like if you can manage not to get complications or manage complications better, then your patients are more likely to go home. So for all the non-believers, we always look at international data. We have a strong ECMO program, so we are believers, and this is what happened in last year. So to just tell you, the total is a survival rate of 56% went home. And the three categories are whether they came after bypass, did they come on ECMO, that is inability to wean from bypass. Semi-elective is children who are not arresting but who are likely to arrest. We go on electively, severe low cardiac output, liver dysfunction, renal dysfunction. We don't want the multi-organ failure to set in. And eCPRs are children who have actually arrested, and we have a code, and then we have a protocol where we put all our children post cardiac surgery on ECMO after CPR if they don't come out of a CPR. So we call the whole team by 5 minutes, and by 20 minutes if you're not coming back, there's most likelihood that not most, all of them go on eCPR, that is ECMO. So even their survival is about 50%. So all in all, it really works in a pediatric cardiac ICU. We had 3 myocardial failure patients. We had 1 respiratory failure patient. So once our experience in this is so vast, and VA ECMO, cardiac ECMO is so much difficult than veno-venous ECMO. When those occasional patients come, it's much easier to manage, and our outcomes get better. So I'm going to wrap it up now. I've got another minute to go. So 10 commandments, what I would like you to take home is to consider ECMO early. I'm not saying initiate ECMO early. I never said that. So consider ECMO early and keep considering every 6 to 12 hours. Once you say no, you need to tell when they need to call you again. What is the triggers? Just say, don't close the door. And don't use the lungs when you're on respiratory ECMO. Please don't bang the lungs. Saturation of 80% is fine. Know your circuit and know your cannula. I showed you a big shopping, of oxygenators, different cannulas. Know them very well. Please understand oxygen delivery, the concept of oxygen delivery. Anything to minimize sedation. There is a big debate going on. A patient who's on respiratory failure, adenovirus, you put them on ECMO. When do we do tracheostomy? If you're expecting somebody to go to 2 weeks, please do a tracheostomy, wake them up, put them on HFNC through the tracheostomy, make them sit down. Do that, mobilize them. Don't get them into the side effects of sedation. You know what the side effects are. So ECMO wean not too early, because then you will go up on supports in cardiac ECMO, or you go up on supports on the respiratory, on the ventilator. So not too late also, because then infection is one of our major killers in patients in ECMO. And it takes a village, and don't think that you can do it alone. It takes a lot of people. It drains you out. It pushes you. Sometimes you have 3 mortalities one by one, and then you'll have 4 survivors. So it is very, very difficult, both mentally, physically, and everything. So it takes a village. Build a village. review our work, always celebrate success because it's 50% chance. So keep on celebrating success and talking to each other about it. We partner with ELSO because they give us data, our own data, others' data, and they criticize us, they help us with small things. So you should partner. And finally, we are in an intensive care conference. I want to finish off by saying, without a team, these guys, I won't be here. I won't be doing what I do. And finally, I want to finish off saying that many people think ECMO is, if you learn ECMO, you're fine. So they do online courses, come and visit us, observe. ECMO is not that. ECMO has to be hands-on. You can do other things on workshops and stuff like that, but ECMO is. So the point I'm trying to tell is, if you can manage ECMO, that's not what you need. You need to manage the ECMO and the patient on a whole. So their intensive care becomes very, very, very important. So you have to learn intensive care and ECMO. So please go to centers where you can learn intensive care and ECMO, not places where you want to only learn ECMO. Okay, so strengthen your intensive care principles, your ECMO results will get better. Thank you.
Thank you, Dr. Shetty. Any questions from the audience? How long you can continue ECMO in case of adult and pediatric cases safely, Dr. Shetty?
Yeah, so the endpoint of ECMO is really, I feel, is a couple of things. I don't know exactly how many, but I'll tell you what they are. One is futility. Are you doing this just for the sake of doing? Is there a chance that the patient will recover? Number two is if your complications catch up, then that will be something that the ECMO will stop by itself, And number three is financial. So long is as long as you can afford, and is there a chance to live, and there is an answer that they will have a decent life afterwards. So there are patients who have stayed on ECMO for, in our center, 95 days. In abroad, about 400 days. So sky is the limit. So as technology improves, infection control is done better. And finance sorts out.
Commonest complication is infection, mainly.
I wouldn't say that, but it depends on which part of the journey you're in ECMO, right? So if a new center starts ECMO, it'll be, you can't even go beyond 1 day. You can't cannulate. You'll cannulate, you won't get flows, and patient will die. So then that center won't have infection concerns. A center like ours, which that is not a problem, our main fight is infection, yes.
In case of VA, complications are more, I think.
Sorry, in case of VA?
VA.
Oh, yes and no. There's not much data on that, on some sets of ECMO. But VA people are more morbid and sometimes they are ECPRs also. So it's much more difficult to look after them. And you're always afraid that there's a chance of a stroke. So a neurological injury, which is detrimental. So that's something. See, infection we can control. I've been in centers where infection control is strong, but neurological injury is not something I can tell the patient kuch nahi hoga. You can't say that. It can happen to anyone.
Thank you,
Yeah.
Dr. Shetty.
Yeah, thanks.
We have faced that in our part of the country, only 1 or 2 states were not. The main problem we are facing is the financial problem. So what is the plan that how can we make it?
So it's a very good question. I recently co-authored a chapter in the Red Book of ELSO. If you guys get a hand on that, you should read it. It's one of the best textbooks ever in any specialty. So we wrote about economics, right? It's a chicken and egg situation, right? What we did, we fixed our economics in 2006, right? The first ECMO in this country in 1991 was done in BM Birla by Dr. Shetty's team. It is documented. It's there in Indian Journal of Extracorporeal Technology. 3 patients were put on cardiopulmonary bypass for a prolonged period of time and survived, and they used a centrifugal pump in the ICU. From there to now, the biggest thing we have done is sorted out the economics. So all those patients I mentioned did not pay from their pocket. They were cross-covered by someone. So we have done 1,000 plus ECMOs in Bangalore for free, completely free, cross-covered from other patients through insurance. It's a little complex, but we cross-cover. What it does is, you do many. So we went for 3 years in 2005 with having 1 or 2 survivors, and one tetralogy just got better and came off ECMO. Then everybody came and told, oh my God, you know what, ECMO works. Right? So you got to do this journey, right? You got to do arterial switch operation. Many died, and then we came up. Unfortunately, we are in an age where we don't want to risk ourselves, risk our time, money, establishment, all this, so on, to push. People are going to die in a new center initially. You're not going to get good results. So if the economics is not sorted out, you'll do one, he'll spend a lot of money, he'll die, 2, 3, then you'll stop because it's too expensive. So if economics is going to come in the picture, you will never establish a good ECMO center. Never. I'll guarantee on that. The learning curve is very, very expensive. So the government, if there's anybody here in the government, probably they should use our taxpayers' money to, push an ECMO program in 5 parts of the world. Yeah, that's what I would suggest. Anybody, any central institutes, they should push. They should really push. Okay.
Now, I have seen in AIMS Delhi,
Yes.
they are using regularly.
Yes.
There is no problem.
I'm not talking about AIMS, but there's a difference between regularly using and having good outcomes. A lot of them talk about I have weaned this ECMO. No, he has to go home. He has to come back for his, come back and celebrate the next birthday with you. Yes. That's the challenging part. Weaning ECMO, I can wean all of them. 78% of them weaned off last year. Only 56 went home. That conversion rate, 50s to 100, 100s to 200s in cricket, like that it is. Okay? Yeah. Thank you.
You should go home.
Yeah, should go home. Yeah. Thank you.
Thank you. Thank you, sir, for the wonderful presentation. I would like to request Dr. Sir, please be on stage, please. Yeah. I would like to request Dr. Devdatta Mukhopadhyay to please hand over the mementos to Professor Subroto De and Dr. Riyan Shetty.
It's really okay. Okay, thank you very much.
Case presentation boards.